Okay, good afternoon, everyone, or I guess it's evening. Good evening. We're glad you joined us. So my talk is kind of what we know already, kind of just a summary of coronavirus, what is, COVID-19, everything we've been hearing about nonstop for the past 6 weeks, and just kind of where do we go from here. Okay, just generally speaking, I think we've learned a lot of this already, but the corona is just from the Latin word for crown, and it has to do with the appearance of this virus under, electron microscope. There's 4 main subgroupings of the coronaviruses. They're alpha, beta, gamma, and delta. They initially identified them in the mid-1960s, and currently there's 7, including the new COVID-19, that can infect humans. So this is an image that we've all become very familiar with, and it's just what the coronavirus looks like under a microscope. All right, these are the 7 that are known to infect humans. First 4 really don't cause any major infections in non-immunocompromised people, just symptoms like common cold. And then the last 3 are the ones that are of concern. So what are the coronaviruses, generally speaking? So it's a very large family of viruses that mostly cause mild to moderate upper respiratory infections if they do infect humans. There's literally hundreds of them. Most of them just stay among animals, and anytime the virus is able to jump from a human, from an animal to a human rather, that says jump to human from animals, it's called a spillover event. So that's what's happened with COVID-19, and that's what's happened with the other 2 that were of concern in the last couple of decades. So the 3 new coronaviruses that have emerged from animal reservoirs over the past 2 decades are the ones that cause really serious illness and even death. I thought this was a great image. I found it in the Journal of Advanced Research, and it just shows that, typically it's going to be either from mammals or birds that the transmission is occurring. And you'll see any of the ones that are solid lines are known transmissions, and any of the dotted lines are supposed transmissions. And as you can see there, that the only ones known to infect humans are of the alpha or beta subcategories. And they're not saying that we can't get infected by gamma or delta, just none known yet. So that kind of goes back to what you'd said. Maybe there are, other virus infections, just like this one, that maybe we just didn't know about because maybe it wasn't serious enough. And if you're not looking for something, you certainly can't find it.
True.
Okay, just a summary of the big 3. So if you've been in medicine a little bit, or even if you've watched the news in the last couple of decades, you know about these 3. So we have the SARS, and that was, it emerged in 2002. And it caused the severe acute respiratory syndrome. That's how it got its name. So it was officially named SARS, and then CoV for coronavirus. And it emerged in China as well, and it spread to quite a number of countries within a few months. So there was a great concern about it. So a lot of people started doing some research on it. It really got the attention of the research and medical community. This one mainly traveled with people who were international travelers, and that's how it got from country to country. About 8,000 people became infected, and there was anywhere from 775 to 800 deaths is what I found on that. It became, the disease kind of disappeared after about 2004, and they linked that to tracing and isolation techniques. So I think that's why countries are trying to do what they have done with this one, because they thought maybe they can control it like they had done in 2002, but it just wasn't as effective. Then just a few years later, we had the MERS, and of course that one was named because of where it originated. It originated in the Middle East, and it had a similar type effect where respiratory distress, it was transmitted from the animal reservoir in camels, and was identified in 2012, and it continues to cause outbreaks today. It's localized and can be seasonal, but it's here to stay. which is what I guess they're anticipating that might happen with COVID-19. Okay, and then we have our most recent one, which originated in China just this past year, and it is they are classifying it as SARS, but it's novel. It's different than the original ones, which is why it has the 2 after it. They are. It is a. It does cause acute respiratory distress, similar to the original. It was declared a global pandemic by the World Health Organization in early March. And then as of yesterday, these are the global numbers that I could find. And you can see we're approaching the 3 million confirmed cases with almost 200,000 deaths.
That's a lot.
It's a lot.
It's a lot.
It's a lot. And that number is going to grow once we have more testing capabilities and all of that.
Yes, which will decrease its mortality percentage.
Sure.
I think it's going to end up being essentially like influenza, like H1N1, influenza A. I guess A is, which is the bad one? B? I think influenza B is the bad one. Yeah, B. Mm-hmm. It was about 0.1% or something like that.
Yeah, and will we truly ever know the numbers? Because there's going to be so many asymptomatic people. Probably not. Yeah. Okay, so now that we know it's a community spread, I think we've got that out there. The mitigation strategies, and this is where we kind of need to open up the discussion. So we have a personal responsibility to, have good hygiene, wash our hands, cover our coughs and sneezes, face coverings. That's a whole nother debate.
We're going to have it.
Yeah, are people going to start needing to do that on a regular basis, not just, during this initial phase? And how do people feel about that? Are people going to be responsible? Can governments do more than just highly suggest? Yeah. Social distancing, we're all very familiar with that now. I'm sure most communities are doing some form of this, limiting these large gather events. Most places are doing stay-at-home orders, I think, other than rural areas. Working from home, limiting outside work to essential workers only. How long can we do these sorts of things and have people survive? We have to look at the cost associated with these things as well. And then, of course, institutions and even people in their personal spaces need increased surface cleaning. Businesses, public places, your cars, your, anywhere that you think that you could spread germs. What's our responsibility to have additional techniques to help control this? All right, so these are the official CDC recommendations for healthcare facilities, which I thought was, most of us are going to be familiar with these, but I actually wasn't familiar with some of them. So I think we can discuss each of these points. So the minimizing the chances for exposure. And that was some of the early things that I think we saw in a lot of our hospitals was, they had limits where you can come in and where you can exit, just so you can limit the amount of places that people are going to be infecting. Then, then they went from there to limiting who could come in, when you could come in. Are we going to change visiting hours? Can visitors come at all? Adhering to the...
Can I add to that?
Yeah.
You don't mind the interruption?
No, I want you to.
So let me give you this interruption. So one of our team members, I'm not going to say who it is, but I'll just say that he had to take his dad to the hospital for acute belly pain. Went in through the emergency room, was told, you can't be here anymore, you need to leave. Left, ended up going home. By the time they made it home, they got the call, your parent is dead. And the impact of that on him not being there for his dad. So yeah, we can start talking about how are we going to, how many times have we had patients who, through heroic efforts, they just aren't going to make it. They go into multi-organ system failure, and they're not going to make it. And the families are there around the patient to be able to have that time to grieve and say goodbye. Will we lose all of these things? Yeah, I get it. For right now, we sort of are where we are, but we can't lose our humanity.
I agree
I'm
with you
worried about
completely.
this. I'm really worried about this.
Right. I think all of these, especially, we're talking about this is, 6 weeks that we've really been doing these sorts of things, and some of them have gotten, more, have become more strict as they've been trying to control the numbers. And I understand all that. But I think these are things that we really need to discuss, because if most predictions are right, this isn't going to go away, and we're likely going to have another resurgence once communities start opening.
We need a vaccine.
How long? And what are the costs for all of these? And it's a terrible tragedy. And I'm sure you've heard that we've had patients of our own that they're coming in for heart surgery, no small thing.
No.
And no family there. They were brought in through the ER, and they've been an inpatient alone.
Yes. Yes.
And I mean, I know hospitals are doing their best, and phone calls and FaceTime, and we're lucky that we have technology. But that patient was scared.
There's nothing to replace a kiss from your loved one to go into the operating room for a surgery that that nothing is benign no matter what, but heart surgery is bigger than most. Sorry, but there's nothing that can replace that.
Or even on the flip side, I've had 2 friends deliver babies, and it's a beautiful, happy event.
Yeah. Alone.
And well, one was able to bring 1 family member, and the other none.
None. Wow.
That's something.
Yeah, that's sad. Okay.
Yeah. Okay. And moving on down the list here. So then we have adhering to standard and transmission-based precautions. Now, this is something that we, as healthcare workers, do every day. I think it's kind of interesting that they even put that into the list there. But, we have to assume that every person that we come into contact with is infectious. Not specifically for COVID, but I mean, we do that anyway, right? So we should be taking those precautions, wearing our PPE. Maybe it's a good wake-up call for people who become laxed. There is certainly protocols put into place to protect us as healthcare workers that we should be following all the time. Yeah.
We used to eat in the operating room back in the old days.
Yeah.
Have Cokes. I've
heard of people even smoking.
Yeah.
Yeah.
We did that too.
Yeah. Patient placement protocols. I think all the hospitals that we have dealt with certainly had something in place, whether that be, negative pressure rooms or, COVID wings, suspected COVID patient areas, to protect the other patients there and to limit exposure for the healthcare workers. I think many were doing similar to what we had installed, plans for certain employees working in certain areas to try to limit, secondary exposure. Taking precautions during all, aerosol generating procedures. Initially it was, you saw the changes. First we were doing, PAPR suits for everything. And then it was just, well, as long as they're intubated and they're this and, these types of things, we had to start conserving because it's a supply thing, All right. Collection of samples. Initially it was, everyone was, you wearing, N95 mask for a swab sample. You have to, do the full gown and all of these sorts of things for suspected patients. But of course, the more we had suspected patients, the less we had supplies, and people started becoming worried that we weren't going to have enough. So CDC changed that to collection of samples as long as you had traditional PPE and it was not during an aerosol.
Bronch.
Yeah, exactly. any kind of procedure that would be, aerosol, then that was fine. Then, managing the visitor access and movement within the facility. So that initially started with minimizing chances for exposure, and then moved to many places, no visitors at all. Limited visitation to no visitors at all. And then, of course, we had movement within the facility. If you weren't supposed to be at the facility for an essential purpose, whether it be, administrative types or even clinical people, you shouldn't be in the ICU if you're not there taking care of a patient.
No social rounds.
Absolutely not. And even limiting the amount of, our team often, we might have someone working in the operating room and someone working in the ICU of the same hospital. Check on your teammates.
Help each other.
Yeah, we're not going to do that anymore, because if that patient's in the ICU, or even if they're not taking care of a COVID patient, you're supposed to limit that, because you could be that asymptomatic carrier, right?
Absolutely.
Yeah. Implement engineering controls. This has to do with we've seen this a lot in some of the retail stores that are still open, putting up screens, any kind of barrier that you could help prevent the droplets, and also asking people to wear masks as soon as they're, at the hospitals, which I don't think is a bad thing. All right, monitoring healthcare workers. So I think we've all seen this, where we're being screened as we come in. We're having our temperature taken. We're being asked if we've had any symptoms. And generally speaking, if you are a healthcare worker, I would hope that you are monitoring your temperature even when you're not at work, Yeah. Training healthcare workers. Many healthcare workers are very trained and understand, of course, about disease transmission, but there's many that aren't, or maybe not as well versed. We've got nurse assistants, we've got janitorial staff, and all of those.
Transportation.
Transport. Food supply and delivery. All of those people were recommended to have special training so that they could really understand the precautions that they needed to take to protect themselves. And thankfully,
and others from them.
Absolutely. And thankfully, I saw a lot of changes in the hospitals that we work in, So that even goes to removing food from, COVID positive patients that maybe aren't on a ventilator. Maybe they're just in the hospital. We have to be careful with all of the things we're taking out of the room. Having dedicated stethoscopes and other kinds of equipment, and making sure that those get special care for being disinfected once they are removed, especially on those face shields that they were wanting everyone to wear. There's a limited amount of those. Most hospitals don't have enough for every single person to have one who was dealing with a COVID positive or possible COVID positive patient. Yeah. That goes right into the environmental infection control. We're, doing more disinfecting, not just of the equipment, but of the rooms, of the hallways, of the bathrooms, all of this.
I'm going to say this. I remember, if I can.
Sure.
I remember a time when you could take a person and blindfold them and take away their auditory senses as well, and put them in a car and drive them someplace, get them out, and bring them into a hospital. They had no idea they were in a hospital. They couldn't see, they couldn't hear, but you could smell the cleanliness. You knew you were in a hospital just by the smell. I have been to hospitals, none here where we are now, but in a previous place where I lived and worked. There were so many flies around the waste area, where the environmental, the biological waste would go. It was so filthy that if you did that same experiment, from the minute you walked in the hospital, and they prettied it up, they made the entrance look beautiful, but you could smell how disgustingly filthy it was. And I remember going back even farther. a hospital in New Orleans that was run by the Daughters of Charity. Hotel Dieu Hospital was the name of it. It's called University Hospital now. It's with I think it's LSU. But if you were walking down the street or down the hallway and you passed a piece of trash, like a wrapper, and a nun was behind you.
And you didn't pick it up?
And yes.
Yeah.
They were going to give you a tongue lashing and you were going to pick that up. Now, they didn't mean it in a mean way. It was a teaching moment, but those were their expectations. We need to get back to that.
Yeah, and I absolutely agree with you. How many times have you seen someone step over that piece of trash?
A lot. More than I can count.
Now, and I'm having trouble now with when I see a piece of trash and I don't have any gloves, you know, out in the world.
Yes.
I'm hesitant to pick it up because I don't really know, like, you know, you're a little, is it worth it? Do I not? But normally that's a thing that bothers me.
Before all of this.
Before all of this.
You just pick it up, put it in the trash.
Yeah, especially.
And think nothing of it.
Right. And, you know, going back to this thinking of this environmental infection control, this is something that's bothered me for a long time, is, you know, we all want quick room turnover. We got another case, we got a surgeon who's got, you know, cases all day. How quick is too quick? Because I know we've been in rooms where, you know, everyone's on them to get it done. I'm not putting the blame on, you know, people who are turning the rooms over, but sometimes you see things that are missed. And if you see the things that are missed, imagine what you don't see.
Yep. Agreed. 100%.
Yeah.
Agree with you 100%.
Yeah. Okay.
Yeah, we need to start cleanliness. How does that saying go? Cleanliness is next to godliness. Isn't it the way that they say?
I mean, especially in a hospital environment, you would think that would be our number one thing. Because what's the big thing that everybody gets tracked on are patient infections, secondary infections.
Absolutely.
You know?
Absolutely.
Okay. And then lastly, the communication protocols between facilities and health officials. Making sure that different hospital systems, surgery centers, wherever, when they have those positive cases, that they're sharing it with health officials and other hospitals in their area so that everybody can kind of assess what's going on.
It is time for us to put competitiveness aside. I think in the sake during the era of this latest pandemic. No question about it.
Absolutely. Okay. I think we covered those pretty well. All right, so what are our expectations of what's going to happen? Well, I think we're already starting to see that locally. We've had some new things happening today. You know, communities are going to be lifting some of these restrictions in phases. We're seeing that here in Texas as of today. We're going to have increased testing capabilities, which of course is going to lead to increased overall cases.
All healthcare work. Anyone working in healthcare needs to be tested.
Absolutely.
Because I can almost guarantee you that there are, I just can't wait to see what the numbers are.
I think it's going to be shocking.
I think it is too.
Yeah. And then, are we expecting a second wave of infections? I think we are. But I also think that, you know, there's ways to continue moving forward, not regressing back to where we are, and still have a responsible techniques to manage them. Okay? All right, so here's where we get to have some real discussions, some questions that I thought were important. Did we over-respond? What do you think, Joe?
It depends on in what context do you mean?
Well, I mean, in all contexts. Now, I'm not really talking about planning. I think you can never plan too much for the unknown.
You mean, did we respond by shutting the country down? Over-respond? Is that what you're referring to? Like stop all elective cases?
Yeah.
I think that the answer to that for me, I think I can answer that yes and no. Yes and no. I think when we didn't know what this was, no, I don't think we ever responded. I think once we recognized what it was and what it wasn't, then I think we did overreact.
Well, and what do you think about? I know we've talked about this off air, I think, but why didn't we happen like New York?
That's another very good question.
I mean, specifically us, because we're in a big, big city area.
Well, even Miami. Miami, we had about San Francisco, Los Angeles. I mean, they had a few pockets here or there, but nothing like New York. Nothing like New York. And it's a really good question, and I really don't know the answer to it. I don't know. It's going to be interesting to see. My first thought was that the virus in San Francisco, because of course we don't know how many cases they really had in China.
Right.
So was it they really didn't have that many cases, and that the virus in San Francisco or Washington State in that West Coast was somehow different, that it had mutated enough by the time it got to Italy and then New York that they're not the same virus. I mean, I think they would have told us that by now.
You would think.
But they haven't.
Yeah.
And that could be because they don't know. I don't know.
Yeah.
But it is odd to me that New York fell apart the way they did.
Yeah.
But not everyone.
No.
Because it was more the public hospitals.
Well, you know what I was thinking? What about New York is lots of big cities use mass transit, but they really rely on it there.
Do.
And I wonder if that was just a real place for community spread. You're very close together. Subways, they're probably not cleaned very often. I don't know.
Well, I mean, I don't know either. I can't answer the question yet because I just simply don't know. But I think that that New York, I don't think has a higher African American population, which seems to disproportionately have more problems than do others. I think they were 58% of all the deaths were African American, but yet they only constitute 13% of the nation's population. So that's troubling when you look at that.
Yeah.
They disproportionately have sickle cell anemia. There are things that are, racially disproportionately higher in depending on whether you're African American, whether you're Asian, whatever it may be. So I don't know. It's a really good question, but I don't know if that was the issue. If the fact that they had nursing homes with infected patients and that spread like wildfire. Was it governmental mismanagement? Was it just a different virus mutation? All of those things I don't know the answers to, but I think we need to know the answers to those things because there was a completely different experience here in Houston, in Nashville, in San Francisco, even in Chicago and Detroit, which got an uptick, but it didn't get nearly to the level, again, that New York did. And Miami, Jacksonville, Florida, Tampa. These are not small cities.
Right.
It should have been much worse than it was if it had been anywhere close to the same percentage numbers that we saw in New York.
So do you think that has to do with New York was in the beginning and other places were more prepared?
I don't know. I can't answer the questions. I just don't know. All
right. What about herd immunity? You and I have talked about this before.
England tried to do it.
Didn't work, huh?
No, it went pretty poorly.
Yeah.
It went pretty bad.
Yeah. I think if we protect the immunocompromised and the people who are most at risk, that might have been a way we could go.
Yes, they let it rip.
Yeah, they just said, eh.
Yeah. Well, I don't think they quite went, eh. It might not have been, eh. I think it was more, we're going to make this as a conscious decision.
Right, and everyone's going to get it.
Pull it back.
Yeah. I meant, we're all going to get it anyway. So, yeah. Okay, and then what about the economic impact versus protecting human life? Now, of course, we want to protect human life any way we can. That's not what I mean at all.
But economic impact impacts human life.
It does, especially the very disproportionately to certain class groups.
Yes.
And they're going to suffer for a long time.
Yes.
I mean, I think we're all thinking about this a little bit, but it hadn't even occurred to me that people who aren't working, children.
Could you open the phone line? Sorry.
People who aren't working, children who aren't going to school, that rely on those meals. They don't have the protection.
I know, and that's sad too.
Yeah,
But
and I think
that's going to become that's going to become a real interesting discussion. That there are kids in this country that have to rely on school for to get a meal. I mean, there's some things that
it's just things we did. I mean,
that really concern me.
Who would have thought that a pandemic would affect all of these things?
Mm-hmm.
Not just the sick.
Yeah.
Not just people being out of work.
Mm-hmm.
There's just such a big trickle-down effect.
Yes, absolutely.
Yeah.
And a health effect.
Yes.
Because if you're not eating, it's affecting your life. If you're not going to the doctor for various things, typical illnesses that are easily managed, it affects your life. If you are now unemployed where you were and you can't take care of your family and you start drinking or abusing drugs or become desperate and start stealing or whatever it may be.
Whatever it may be.
What about elderly people who have no one to take care of them?
Yeah.
I mean, so societally, this has been, in my view, a disaster.
And what should we do about schools? I mean, I think a lot of decisions have been made for this school year, but what are we going to do about the fall? If there is a resurgence, are we going to cancel schools again?
Well, I think fear about, how sick will these kids get? And then, of course, schools, we know that they, it's how you get German measles and everything else. That's how you get it, right?
Right.
Going to school. So, and flu and everything else, colds, but they're all doing that.
Well,
but
not just the health aspect, but what about the parents and taking care of their kids? This can't be a permanent solution.
No, but I don't know that they should have closed the schools. I think they didn't. Once they knew kids were likely not going to, they would have been vectors, but I think you could have managed that.
Yeah.
I think we should have. I don't think we should have closed the schools.
What will we do and what should we do for this second wave? Assuming it's going to come.
Yeah, I think if it does, I don't think it's going to be, I think it'll be more blunted. I think this is going to be like H1N1. I remember H1N1 was so crazy. We had so many patients on ECMO.
Everywhere.
Massive amounts of ECMO. Do you remember those years?
Yeah.
Remember that? I was calling you all the time.
Yep.
Remember?
Yep.
It was crazy. And the respiratory, the ARDS rate was huge. And our systems at times were very, very, very stretched. Really struggled a lot. But we got through it and we're fine. And that was a highly infectious disease as well. I don't know that it's less infectious than this is.
Yeah.
I don't know.
I don't
know that that's true. It's a virus. It's easily transmittable with respiratory droplets. If you touch a surface where it was and then touch your eye, you're probably going to get it. Yes, we had a vaccine, but we didn't have a vaccine at the time.
Right.
The influenza, the H1N1 was unique, and you really didn't have good immunity. Then they came out with Tamiflu, which was very helpful for it. So a treatment like that we need.
We need something like that.
There's real debate about the hydroxychloroquine and whether that really does work or not. There's debate about it with or without the azithromycin.
Well, I think people are panicking to try to figure out something quickly now, and time. We're going to need time before we know what is a real applicable treatment, if there one even exists right now.
Absolutely.
Yeah. And any other thoughts?
No, I don't have too many other thoughts other than I think that novel respiratory viruses are going to occur. I think they're going to continue to occur. Cross-species transmission is going to happen again. I'm doing a talk, I think it's tomorrow, I think it's tomorrow, on passive antibody treatment.
Yeah, I think that is tomorrow.
The convalescent plasma. And I learned so many interesting things. I've never been as interested in this. I'm looking, by the way, in case anybody out there or anybody knows of an incredibly talented virologist. I've been searching for one, trying to find one that I could cajole or trick into coming to the studio and getting on the program. But I've never really had so much interest in viruses as I do now. And they're fascinating.
They're fascinating
things. They're not alive because they don't meet the definition of being alive.
Because they don't have cells. But
that and they can't replicate without a host.
Right.
But they're sort of like little mini machines. But
there's a whole debate in the scientific community as to whether or not to change the definition of what is alive based on viruses.
Yes. It's really fascinating.
It is.
So, I think it'll be, and where did they come from? Were they the first cells and we evolved from that, becoming more complex, from RNA to DNA and double helixes and becoming more, cells becoming more complex? Was it somewhere in the middle? Was it two different paths? Do they have an alien origin? I mean, and when I say alien, I don't mean alien beings that came here. I mean space stuff that came to the United States. Are y'all laughing at me over there? First contact. But, that's how most of the stuff that's on this planet got here, right? From impacts and becoming, a different thing. So I think it's fascinating. I've been reading a lot about it. And but the therapeutic plasma, tomorrow's program is going to be really interesting because I've learned some really, really neat things about that. And of course, they're using it now. It may sound like it's new. I'll give you a preview. I'm only going to say I'll say it, even though it's programmed tomorrow. Do you know how long therapeutic plasma has been being used in the U.S. or in the world, but specifically in the U.S.?
No.
Take a wild guess. How many years? Take a wild
25.
guess. 25. Yeah. Try again.
100.
Try again.
200.
No. 130. 130 years.
Wow.
130 years.
How come we don't hear about it more?
That's one of my questions for tomorrow. Is if it's been around that long, how could it not? Why are we're doing it again for this? And it may be a good idea, but
that'd be great.
If it was that good of an idea, there's been a lot of opportunity over the years. But when you don't have a vaccine or an appropriate treatment for it, it's kind of like it's all we got.
Yeah. Use what you can.
Use what you can.
Yeah.
But I can't say that I'm that excited about convalescent plasma as the end-all, be-all of managing COVID-19 infection. I think it's going to come and go like it has for years. 130 of them.
All right. Well, that's everything I got.
That's everything you got. Okay.
Yeah, thank you. And
thank
we'd
you.
love to hear from anybody in the audience on your thoughts about these things.
Do we have anything on FaceTime or the other thing? Twitter?